All aware that my name is Pankaj Arora. I work for a company called Somnomedics as a country manager for Indian subcontinent uh, and certified in clinical sleep health and all other certificates. So Dr. Ritu has given me topic to speak on technical specifications in polysomnography. But I thought I slightly modified it and thought it should benefit all of us, because going into technical details, going into multiplexers and digital things will not help us, because we are a clinical, we should look for clinical things. So I prepared this presentation accordingly. So the objective of this session is we will look into the polysomnography diagnostic levels. We will also look indications of these different diagnostic levels. As Dr. Vikas Mittal, one of my friend, discussed this in sleep forum. So I thought, let me look into this aspect also. And we will also have case discussions, because anyway, we are a small team, so we can have a case discussions. I will put 5 cases in front of you, and then we'll see which case is good for which level study. Then we will look for important technical terms used in sleep medicine polysomnography, and maybe if we have time in last, we can look at role of each sensor and what ASM recommends. So as we are all aware, polysomnography means, poly means obviously multiple, somno is sleep, and graphy is graph. So we see multiple graphs of sleep as well as respiratory channels, and that is why it is called as polysomnography. So polysomnography diagnostic levels are divided into 4 levels. Basically, level 4 is a basic device which will have pulse oximeter, flow, and maybe one effort, we can say, but generally it's pulse oximeter and flow, and it is called as polygraphy. Why it is called as polygraphy, I'll come to that. So level 3 will have pulse oximeter, flow. It will have both thermistor and pressure transducer, or thermistor or pressure transducers. Then it has to have efforts, both thoracic as well as abdomen. It will have body position. It will also have ECG, and therefore it is sometimes called as cardiorespiratory screener. So level 3 and level 4 are called as polygraphy. The reason is simple, because there is no EEG involved in it. So that is why it is called as polygraphy, simple respiratory channels. Level 2 will have all level 3 and level 4 sensors, but it will also have an EEG sensors, EOG sensors, and EMG sensors, because you need to differentiate between different sleep stages. And that is the reason we have level 2 have EEG sensors also, apart from respiratory sensors. Level 1 will have same as level 2, but it is defined as gold standard, recommended by ASM. So it is done in hospital, in sleep lab itself, with some sleep technologist attending the patient. So again, it's the same thing. Definitions are same. Difference between polygraphy versus polysomnography is you have airflow, SpO2, respiratory efforts, body positions, and snoring. If you add sleep parameters into it, it will become a polysomnography. I guess so far so good. Now, important thing is, what are the indications of these level 3, level 4, level 2, and level 1 devices? We all talk of polygraphy and polysomnography, but nobody speaks about it. So I thought, let me put this into perspective. So when we have a high pretest probability of having moderate to severe OSA or uncomplicated OSA, then we will look for level 3 or level 4. So what do you mean by uncomplicated OSA? Uncomplicated OSA means that you do not have hypoventilation, you do not have hypoxemia, or other things which will come to know into next slides. So it's basically uncomplicated OSA or a clear case of moderate to severe OSA. Then we will look for level 3 or level 4 devices. So how will we know whether it's a patient have moderate to severe OSA? Obviously, we will have to have the patient will be obese, sign of upper airway narrowing, and neck circumference is more than 17 inches in males, 16 inches in females. And obviously questionnaires like Berlin questionnaires will also help in defining whether this patient is having 80 to 90% sure shot that he's having a high pre-test probability of having obstructive sleep apnea, then we will go for this. Please note that whenever we are doing level 3 or level 4 devices study, you need to review the data. You need to review the raw data and document it, that this is done through level 3 or level 4 devices. And most important, if this portable monitoring, I'm saying it's portable monitoring, it's basically OCT out of lab test. So if it is negative, we should always go back to level 1 polysomnography. Very important. So again, now coming to cardiorespiratory study, that is level 3 study, is an acceptable alternative to PSG. If again, it has a high pretest probability of OSA. If surgery is planned for snoring for OSA, then we can look for level 3 study, attended study. We can do this study after surgery for OSA. We can see the effectiveness of oral appliances, then we can do the level 3 study. Or after surgical or dental treatment of OSA, we can look for cardiorespiratory study, but attended. Again, manual scoring or raw data, looking at the raw data is essential. And other important thing is that it should be without any comorbid conditions. So we will see what are comorbid conditions in the next slide. So type 2 is an acceptable alternative to level 1 PSG, obviously when the treatment is urgent, but the patient cannot go to the sleep lab. So then, since level 2 and level 1 is almost same, as I told you, the only difference is that level 2 have same sensors as of level 1, but it is unattended out of sleep lab. So if the patient cannot come to the sleep lab, we can always do a level 2 study. For example, in hospitals also, the patient is admitted into the ward or in ICU where he cannot come to the sleep lab. We can do the level 2 study with the same sensors of level 1 and take this level 2 study to the patient and do the study. So now, what are the contraindications of level 2 to level 4 studies? As I told you before, that comorbid medical disorders like severe lung disorders, neuromuscular diseases, CHF, along with OSA, if we have this in the patient, we should look for level 1 study and not level 2, level 4 studies. Also other disorders like central sleep apnea, periodic leg movement disorders, narcolepsy, cataplexy, insomnia, parasomnia, circadian rhythm disorders, or RMD, rhythmic movement disorders, we should not look for level 2 to level 4 studies. We should always look for level 1 studies. Yes, insomnia and circadian rhythm disorders, I have put it here because insomnia and circadian rhythm disorders will be basically we will use actigraphy in this case, but in some cases we will still use level 1 polysomnography. So I have put this insomnia and circadian rhythm disorders also here. So these are the contraindications of level 2 to level 4 studies, where we will use level 1 studies only. So what I tried to explain you till this time is what is difference between polygraphy and polysomnography, where is the indication of level 4 and level 3 studies, that is after surgery, before surgery, or after putting an oral appliance, and level 2 is used when there is no choice, when their level 1 is not available or it has to go to the patient room. So the summary is, you see, if you do the patient's clinical evaluation, if the OSA is likely, the patient has OSA, as I told you, but it's uncomplicated OSA, then we can put portable monitoring or out of sleep test. Now we need to look at if the AHI is more than 5 per hours, but no CSA, no central sleep apnea, then we can put APAP titration or CPAP titration. But if a patient have AHI, which is more than 5 hours, but CSB or frequent CSA, then we should look for PAP PSG titration. Then we should go back to the level 1 PSG titration. Another thing is, if we thought that OSA was highly likely but we didn't get AHI more than 5. It is still less than 5. It is, for example, 3. Then it means it has failed. So but we knew that patient should have an OSA. Then we should look for PSG again. So we should go back to level 1 PSG again. So now, just a minute. This is not my laptop. This is my father's laptop. So this is some issues. Okay. So now I told you for PSG, there are comorbid disorders like narcolepsy, PLMD, RBD, or rhythmic movement disorders. Obviously, we should look for PSG. Or if there is a very high BMI, or is a patient of OHS, that is obesity hyperventilation syndrome, or if he has a neuromuscular disorder, or he has a COPD, or on 24-hour oxygens, he is taking narcotics, or he has CHF or CSB, then we should look for again PSG. So you can see, so again look for level 1 PSG only. So we do level 1 PSG again. If it is less than 5, it's okay. If it's more than 5, we think if it's less than 5, we think it can be case of narcolepsy because he still have EDS, excessive daytime sleepiness during the day. Then we can do MSLT again, which is again level 1 PSG and multiple sleep latency test. So again, if it's more than 5 per hours, we can do the PAC PSG titration or a split night study. So you can see now, so level 1 PSG is again a gold standard, and a lot of cases actually we do with the level 1 PSG only. Only we look for portable monitoring or a out of sleep testing. We only look for OSA, which is uncomplicated and where we know that it is a clear case of obstructive sleep apnea. So far so good. So what I will do is I have put 5 cases and we'll discuss, since it's a very small group anyways, we'll discuss so which level is used for this particular case. So this is a case 1. A 42-year-old man referred to the sleep laboratory with a long history of snoring, witnessed apneas, and daytime sleepiness. Body mass index is 31 kg per meter square. So it means he's obviously obese, high obesity, severe obesity, we can say. Very crowded upper way. Neck circumference is 17 inches. Unattended level 3 sleep study found an AHI of 3 events per hour. And SpO2 lowest was 89%. Patient reports that he did not sleep well. So which of the following we should do next? Repeat level 3 study. We should look for attended PSG level 1. Tell the patient that he doesn't have OSA because anyways we have seen it's 3.5 only. Or refer him for an oral appliance or upper airway surgery treat. So what do you think? We can discuss this. So I told you, if it is a case of surgery, we can, if pre-surgery, post-surgery, we can do level 3 study. Attended cardiorespiratory smear. In this case, AHI is of 3.5 events per hour. Body mass index is 31 kg per meter square, but unattended study level 3 says AHI of 3.5 events per hour. So what should we do in this case? Should we repeat this level 3 study? Or should we do, should we tell him that there is no obstructive OSA? So you can go back home. Any comments? So what we'll do is we should do attended PSG in this case. As I told you, if it fails, we should go back to the level 1 PSG. So we will do level 1 PSG in this case. So case 2 again, a 38-year-old man was referred to sleep center with a history of loud snoring that bothers his wife. The patient denies daytime sleepiness. His wife has never noted breathing pauses. Patient has been evaluated by ENT who recommends upper airway surgery for snoring. Examination reveals he has a long uvula but a minimally crowded upper airway. His neck circumference is 15 inches and his BMI is 22 kg per meter square. Which of the following would you recommend as per what we have learned in last 8 to 10 slides? Proceed to have the upper airway surgery, schedule for a PSG, schedule for oximetry and flow level 4 study, schedule an unattended level 3 study. So this case is basically if you see, it has a neck circumference of 15 inches only. BMI is 22 kg per meter square. So he is not an obese patient. He is okay. But he has a history of loud snoring that bothering his wife. So what should we do? Is it a clear case of obstructive sleep apnea? No. So what should we do? Because it's not a clear case of obstructive sleep apnea. So we should not do level 4 study. Either we should do level 1 PSG or attended level 3 study. Not unattended, attended level 3 study. So case 3. A 55-year-old man was recently diagnosed with congestive heart failure. He is treated with a beta blocker and other medications, but continues to have a nocturnal dyspnea and frequent awakenings. He reports mild snoring that is unchanged. On physical examination, he has minimal upper airway crowding. He has minimal upper airway crowding. Which of the following do you recommend? He has CHF. He's been treated on beta blockers, other medications, but he still have nocturnal dyspnea and frequent awakenings. Mild snoring that is unchanged. What should we do? Level 4 study, level 1 PSG, trial of hypnotics, or unattended level 3 study? Any takers? You can actually talk. We are anyways for small group.
Level 1 PSG.
Sorry?
Level 1 PSG.
Yes, level 1 PSG, because it's a case of CHF. So, and it will have a lot of central apneas in this case. So we have to have attended level 1 PSG.
I think Pankaj, here you should explain more why level 1 when especially clinical condition are not much there, right?
Yes, I told you clearly, Ritu, that only level 3 and level 4 will be used when there is an uncomplicated OSA, and when we know whether it's a clear uncomplicated OSA means there is no other comorbid conditions like CHF, neuromuscular disorders, central apneas, OHS. So when it is a clear case of uncomplicated OSA, as I told you in very previous slides itself, then we always look for level 1 PSG. So it's a clear case of CHF. We will have more of central apneas. We will have more of obstructive sleep apneas. And in CHF patient, please mind it that CHF patient will not have daytime sleepiness. It may happen. It may that they may have daytime sleepiness. They may not have daytime sleepiness. But so to check this, we need to have level 1 PSG and not level 3 or level 4. Clear? So case 4, again, a level 3 test is performed and the results are listed here. The patient reports loud snoring but no daytime sleepiness. What do you recommend? His monitoring time was 8 hours. AHI was 4 per hour. Total AHI was 4 per hour. But events were 16 obstructive apneas, 16 hypoapneas. But total desaturation was 70. With oxygen desaturation index was 10 per hour. His lowest SpO2 was 83%. We can again read a level 3 test is performed. AHI is 4 per hour, 16 obstructive apneas, 16 hypoapneas. Desaturation was 70 with oxygen desaturation index was 10 per hour. So lowest SpO2 was 83%. So what should we do next step? Should we go for PSG? Should we evaluate the raw tracing? Should we do the treatment of snoring, or inform the patient OSA is not present because its AHI is only 4 per hour? So go back what I told you earlier in the last few slides. AHI is 4 per hour. It's a level 3 study, but you can see oxygen desaturation index is 10 per hour. So oxygen desaturation index is much higher as compared to AHI. So we need to look at the raw tracings. Actually, we need to look at evaluate raw tracings or look for PSG. So it says evaluate raw tracings, or maybe yes.
Pankaj, explain here why you want to look for raw tracings here?
Yes,
Explain it clearly.
that's what I told you, Dr. Ritu, that if you see his AHI is 4 per hour. What do you 4 per hour means it is less than 5. So it less than 5 means what? Less than 5 means it is he doesn't have any obstructive sleep apnea. It means it says this. But if you see his desaturations, which is 70, and oxygen desaturation index is 10 per hour. So it means he is 10 times per hour is getting oxygen desaturations, and his lowest SpO2 is 83%. So it means something is wrong here. It means something is wrong here. And that's why I told you previously itself in the first 2 slides itself that when we are looking at level 3 study, we should not give the report directly to the patient. We should look for the raw tracings. If you look at my first 2 slides,
Basically, you want to say here comes the importance of manual scoring rather than auto scored report, right?
obviously manual scoring is important. Second is wherever you find that you think that it is a case of obstructive sleep apnea, but still this level 3 study is not giving you the correct information, always try to look at raw tracings or look for level 1 PSG again. So that's what I'm trying to tell you here, that level 1 PSG is a gold standard.
There is one more point I want to add, Mr. Pankaj. Here you can recommend your patient to go for PSG, because what happens if your patient is already having COPD like condition, in that case it may be possibility ki, these desaturation might be due to COPD, right? So if you have to confirm if the events are during sleep or during wake time, in that case you need level 1 for more confirmation. Right?
Yes, it's not a case of COPD. We are not going to that aspect.
Right.
Yes, COPD or
If
not.
this case, if in case of COPD, such findings are coming, in that case, we should go for level 1, right?
First is that we should look for raw tracings. Maybe there is something wrong, which is they have not correct. Auto scoring has not correctly marked the AHI. So we should look into it. If it is correct, we should look for level 1 PSG. Okay. So, case 5. A 40-year-old woman has complaints of poor sleep with frequent nocturnal arousals. Her husband says that she kicks her legs at night. Only mild snoring and no witness apnea are reported. The patient denies symptoms of RLS. So, which of the following is recommended? Now, again, go back to the previous slides, which I told you that patient with comorbid conditions, for example, OHS, PLMD, central sleep apnea, COPD, now neuromuscular disorders, we should look for level 1 PSG, because level 3 will not have PLM leg movements, and we have to have attended PSG. So in this case, again, we will look for level 1 PSG only. Dr. Ritu, it's clear?
Yes, definitely.
So what I'm trying to tell you is that we should look for a unit which can be used as out of sleep testing, that is portable, can be used as PSG, and can be used as a higher number of EEG channels for maybe for epilepsy patients. So second point is we need to look at important terms used in sleep medicine or in polysomnography. So commonly used technical or oblique important terms in polysomnography is we look for channels, sampling rate, montage, filters, impedance, total sleep time, time in bed, total recording time, sleep latency, REM latency, sleep efficiency, AHI, RDI, epoch. So we'll look into each particular thing like channels. So what is channel basically? So we always talk of when we talk of polysomnography, a lot of different doctors talk of channels. So say how many channels machine do you have? But in actual polysomnography consists of different type of sensors, that is EEG sensors, EOG sensors, respiratory sensors, etc. So number of channels are nothing actually, according to me. It's actually a gimmick made by companies. In actual, the number of waveforms that we see on screen are actually number of channels. So that is, please note this, that what we see on the what waveforms we see on the, what graphs we see on the screen are actually number of channels. Because and these channels views and waveforms are viewed simultaneously to show activity in different parts of the body. So when we talk of, for example, somebody will say, I will have 58 channels, I'll have 68 channels, but ask them, where are these channels? So important is what we need to put on a patient body, what sensors we require. So that is more important as compared to channels. Similarly, what is sampling rate? Sometimes they will talk about sampling rate. So what is sampling rate basically? So what will happen, because all the systems are today is digital recording systems. So what they do is they take the analog output and give the take the input from the body, amplify it, and give the output to the computer. So what we need to do is we need to sample the waveforms, and we need to put this waveforms clearly into the PC. So if you see, this is, for example, this is the waveform. So this is basically 1 second. You have total signal of 4 hertz. It is 4 seconds. So this total is 4 seconds, and you see sampling rate of 8 samples per second. And if you see sampling rate of 3 samples per second. So if we are taking 3 samples in 1 second, the waveform will be like this. You see, you are getting a distorted waveform as compared to sampling rate of 8 samples per second, which is much better as compared to 3 samples per second. But what ASM recommends is 200 samples minimum and 200 hertz minimum and 500 hertz maximum for EEG, EOG, EMG, and ECG. Similarly, for airflow and esophageal, it's 25 and 100. Oximetry 10 and 25, and body position is 1 and 1. So this is sampling rate recommended by ASM, which generally is asked in RPSGT exam. So second is montage. So what is montage? Number of channels, sensors, then one pre-select along with sampling rate, which we have seen, filter settings, and sequencing of waveforms that needs to be recorded is called a montage. So this is an example of montage. You can see that there are basically, if you can see, this is sensors, different sensors. We have put the EEG head box, we have put the snoring head box, we have put flow thermistor, pressure, thorax, abdomen, and all other sensors which we have put it here. And you can see the different sampling rate which is shown here. And obviously there will be filters also, which is already there. So you pre-select these filter settings, you pre-select the sampling rate, and then this is the clear case of montage, which has also CO2. But if you see this next, the montage, it doesn't have a CO2. So you can actually pre-select the sensors which need to be put on a patient body, and the sampling rate and the filter settings. In this case, if you see, this is a CPAP, montage with CPAP, while previous montage was without CPAP but with EtCO2. So this is basically montage. So now there are two montages are different, reference montage as well as bipolar montage. So what is the difference between reference montage and bipolar montage? So reference montage is basically when exploring electrodes refer to a common known exploring electrode. For example, F3, C3 and O1 is referred to M2, and F4, C4 and O2 is referred to M1. So basically this reference electrode montages are used in PhD studies, but the other one is a bipolar montage. So what will happen in bipolar montage? Here, basically two exploring electrodes, for example, F4 and C4 will refer to each other, as compared to exploring electrodes which were referred to a non-exploring electrode, in reference montage. So in bipolar montage, two exploring electrodes are referred to each other, while in reference montage, exploring electrodes are referred to particular non-exploring electrodes. So that's the difference between reference montage and bipolar montage. Reference montage is basically used in PhD studies. Bipolar montage is used in epilepsy studies. So this is again a case of reference montage. Again, if you see C4, C3, M1, M2 is referred to a particular reference. And if you see C4 is referred to reference and M1 is also referred to reference, and it is output is giving a C4 M1. You can see the C4 M1. So C4 is referred to reference and M1 is also referred to reference, and output is given as C4 M1. Similarly, C3 is referred to a reference and M2 is referred to reference, and output is C3 and M2. So this is again differential amplifier, which probably will not help you. Another is input impedance. So what is input impedance? Impedance is basically a resistance which we need to have a less than 5 kilo ohms in EEG. However, less than 10 kilo ohm is also acceptable. Now we have to have a filter settings. So what is filter settings? Basically, we have to have a, you see, EEG has certain frequency starting from 0.5 hertz to 16 hertz, starting from delta waves to beta waves. So we need to have those particular frequencies shown in the screen, and we need to filter out other frequencies. So we need to have a low frequency filter, and we need to have a high frequency filter. So low frequency filter is also called as high pass filter. It means that attenuates the amplitude of low frequency signals, and high frequency filter means it is. So you see, low frequency filter is called as high pass filter. It means it is passing the higher frequencies. For example, 0.3 hertz is a low frequency filter. So what it will do is it will pass on the higher frequencies, but it will attenuate the lower frequencies. Similarly, high frequency filter is, for example, 35 hertz. So it will attenuate the higher frequencies, but pass the low frequencies. So that is why it is called as low frequency filter is called as high pass filter, and high frequency filter is called as low pass filter. Now these are the filter settings which is recommended by ASM, which is 0.3 hertz, 35 hertz. EOG is again 0.3 to 35. EMG is 10 hertz, 100 hertz. ECG is 0.3 and 70. Respiration is 0.5, 15. And snoring is 10 and 100 hertz. This is recommended by ASM, and they generally ask these questions in the exam. So this is again the example of filter settings, which is like shown here, high pass and low pass, 0.2 and 35. Now you see this example. This is example of, you can see the stage N3, which is shown here. It's a high pass filter of 0.3 and 35 hertz, which is a correct filter. Now if you see, I have changed the filter settings here. And you see the waveforms of C4M1 and F4M1. Can you see the C4M1 and F4M1? Is the filter setting same? You see the waveforms here. You can see the waveforms clearly, delta waveforms, but here you can see there is no wave. So because I have changed the high pass filter to 2 hertz instead of 0.3 hertz, which was a regular setting of high pass filter. And that is why filter settings are really important. Now, what is epoch? So epoch is what? Page with different channels shown on the PC screen is called as an epoch. So for scoring sleep stages, we need to have a 30-second epoch. For scoring apneas and hypoapneas, we need to have a 3-minute or 5-minute window. So this is basically epoch of 30 seconds. Epoch is basically number of channels or number of waveforms that we see in a screen. Like you have EOGs, EEGs, ECG, EMG, leg movement, snoring, pressure snore, and all other channels like respiratory channels, which is shown in a 30-second window is epoch. Similarly, when we score apneas or hypoapneas, we look for 3 minutes epoch. Now what is total recording time, time in bed, and total sleep time? So time in bed is basically lights off between lights off and lights on. Total recording time is when we start the unit, when we start the unit and when we end the unit. It's basically called as total recording time. Time in bed is basically between lights off and lights on. And total sleep time is total time sleep, spent time in sleep. Means that is total sleep, that is N1, N2, N3 and REM stages combined together will be called as total sleep time. So how do you define time in bed? I told you lights off and lights on. So lights off is basically the beginning of the sleep study.
Mi hanno invitato a questo coso qua, io ho fatto
Excuse me, Mr. Aurora, kindly mute your window, please.
No, non è che siamo noi altri che dopo veniamo fuori, chi ne vede dopo in Eurovisione, così.
Beh, insomma, io dopo li sento dopo. Ragazzi, chi è questo? Ehi, oh!
Siri che
Right. So lights. So what we look at it is what we are looking at, time in bed. So time in bed, I told you it is between lights off and lights on. So what we are interested in actually, we are interested in sleep efficiency. So sleep efficiency will come to next slide. So we need to look at lights off and lights on. We need to define lights off and lights on. Lights off. What is lights off? Basically the beginning of the sleep study when the patient first attempts to fall asleep. So impedance check physiological calibrations are done before we do the lights off. Similarly, at the end of the study, we define lights on. So again, we do the physiological biocalibrations after the lights on. So it's important we do the physiological calibrations before lights off. We do the physiological biocalibration after lights on. And why lights off and lights on are important, we'll come to know. So basically, we started this here, the recording. This is the start time. This is an end time. So this is called as total recording time. So here we define the time in lights off and here we define as lights on. So this is time in bed. So this is the first sleep where we got, and this is the last wake. So this is called as sleep period time. So this is called as sleep period time. And this is called as total sleep time. This is total sleep. The difference here between sleep period time and total sleep time is sleep period time will have wake also. However, total sleep time will only have the total sleep time without wake period. So this is, you see, it has vaso, wake after sleep onset, which is removed from total sleep time, but it has in sleep period time, it has vaso. Sleep period time consists of vaso also. So that's the difference between sleep period time and total sleep time. Now we need to look at sleep onset and sleep latency. So sleep onset, as I told you, what is lights off and lights off, we already defined. Sleep onset is time at which sleep first occurs after lights off. Time at which sleep first occurs after light off is called sleep onset. And this is defined as first epoch of the sleep, regardless of sleep stage, N1, N2, N3 or REM. So sleep latency is again the amount of time in minutes from lights off to sleep onset. So so the amount of time in minutes from lights off to sleep onset is called as sleep latency. So normal value in people is 10 to 20 minutes in normal people. But if he is a patient of, for example, obstructive sleep apnea, there will be different, or he is a patient of insomnia, then there will be sleep latency of maybe more than 45 minutes. So REM latency, what is REM latency? REM latency is the time from the first epoch of sleep to the first epoch of REM sleep. First epoch of sleep to the first epoch of REM sleep, not from the start. First epoch of the sleep to the REM sleep is called as REM latency. It is generally 90 to 110 minutes. So this is basically, if you see this patient is going from wake to N1, it means basically it is that's what I'm trying to tell you. It's sleep stage latency. It's basically is sleep onset. So this is basically sleep onset because this patient is moving. If you see this eyes are started rolling, the chin EMG, if you can see, is going down here. So the patient is actually moving from wake to N1. And next stage, if you go to next page, basically, this is basically stage N1, but the previous epoch will be called as sleep latency is basically at this point, and this is the first epoch where we got the particular sleep, which is basically N1 stage. Now, what is sleep efficiency? So we looked at total sleep time. We already looked at time in bed. Time in bed was lights off and lights on. Total sleep time we have seen, which is total sleep time was without VASO. So total sleep time upon time in bed into 100 is basically called as sleep efficiency. For the normal people, it is basically more than 85% is good. So the other thing is now, what is apnea hypoapnea index? Apnea hypoapnea index was basically AHI. So we look for total number of obstructive apneas, we look for total number of central apneas and mixed apneas plus total number of hypopneas. So if we add all of these, multiplied by 60, divided by total sleep time is basically AHI. But now ASM recommends, instead of AHI, ASM recommends respiratory desaturation index. So it means we need to have a total number of obstructive apneas plus total number of central apneas and mixed apneas plus hypoapneas. Plus we also need to add RERAs into it. Into 60 divided by total sleep time is basically respiratory desaturation index. Sometimes you will find AHI, the patient is having AHI between mild and moderate, but as you add RERAs, this patient will become from mild, he will become probably mild. He had mild AHI, but while adding respiratory, while adding RERAs, it can be that he has a moderate RDI. So RDI is important. So now the last point which I can show is role of each sensors in polysomnography. So what we are looking at in polysomnography? We are looking for respiratory channels. We are looking for sleep stages, as well as we are looking for apnea hypoapnea index. So for having an apnea hypoapnea index, we need to have different respiratory channels. For example, we need to have pulse oximeter to look at desaturations, which is a requirement for anyways for marking hypoapneas. We need to have a thermistor which is sensitive to apneas. We need to have a pressure transducer which is sensitive to hypoapneas. We need to have effort belts because we need to also look at central apneas. We need to have a microphone which is good for snoring. Obviously, OSA patients will have a lot of heart arrhythmias during the night. They will have bradycardia, tachycardias. So we need to look at the ECGs, and we need to have a leg movement. As I told you, we can get the periodic leg movement disorder patients also. So we need to have these sensors, and each sensor have role to play, obviously. So obviously, as I told you, SpO2 is required to see the oxygen desaturations of the patient during sleep study, and that is the reason SpO2 is the most important marker. Then we have to have both thermistor and pressure transducer. As I told you, both have specific roles. Pressure transducer works well with the flow, that it means it is more sensitive to hypoapneas, while thermistor is more sensitive to apneas. So how thermistor works basically? Thermistor works on temperature changes principle. That means if you see, we inhale cool air while we exhale warm air. So it takes the difference between inhaled air and cool air, and that is how it will give you an apnea. So it is not very sensitive to hypoapnea, but it is very sensitive to apnea. Our pressure transducer is more sensitive to hypoapnea. And anyways, what ASM recommends to have a backup, and that is why we need both sensors, thermistor, as well as pressure transducer. So it is also shown here, like we need to have both thermistor as well as pressure transducers, and both have different requirements. Similarly, but in case any of the sensor, for example, nasal thermistor is not working, so what ASM recommends that pressure sensor can be used as an alternative for the apneas also. Alternatively, if pressure sensor is not working, thermistor can be used for hypoapneas. So it is again a backup. Similarly, as I told you, you need to have a 2-lead ECG is good enough, because we are looking for a polysomnography and not for 12-lead ECG, because in polysomnography we are anyways we have to have lot of sensors, And ECG will, second lead ECG is most important because it will give you both bradycardias as well as tachycardias, asystole or any other, for example, atrial fibrillation. So it will pick up the most, and that is why second lead ECG is recommended by ASM. Then you have to have both effort sensors, I told you, thoracic as well as abdomen, to pick the central apneas. Snoring microphone is to pick the microphone snoring sound. And then you have to have PLM, ECG, PLM, EMG. Basically, what you need to do is you need to put this PLM leg sensors on anterior tibialis muscles, which is 2 to 3 centimeters apart from each other, for diagnosing the periodic leg movement disorder or for RLS patients. Actually, for RLS patients, polysomnography is not recommended. But obviously, when we are doing a polysomnography, you can pick up PLMD. So this is what ASM recommends. At the end, this is what ASM recommends. ASM recommends EEGs, frontal channels, F4M1, C4M1, O2M1, and backup F3M2, C3M2, and O1M2 as a backup, plus reference and ground. You have to have 2 EOG channels.
EEG if
Sorry?
F4.
Hello? There's something you want to talk? So we are looking for EEG, that is frontal, central, and occipital channels. So we have to have both F4, F3, C4, C3, O2, O1, and we have to have both mastoids, M1 and M2. We need to have both reference and ground. We need to have EOGs because we need to differentiate between RAM and non-RAM. And we need to also have a chin EMG, because how will you differentiate between RAM and non-RAM? You will differentiate with EOGs as well as chin EMG. Because what will happen during RAM, there will be eye movements, which one will pick from EOGs, and there will be low chin EMG as compared to other stages of sleep. So again, what AEG montage ASM recommends is, basically it recommends 3 EEG channels, 2 EOG channels, and 2 chin EMG channels, 1 mastoid plus reference and ground. But obviously, if we have more EEG channels, it means if we have a backup, it is always better. It means if we have 6 EEG channels, it is always better. So now, if you see, what is the role of frontal, central, and occipital channels? Actually, frontal will give you delta sleep. Central will give you spindles. Delta sleep is a hallmark of basically stage N3. So central is giving you spindle, which is a hallmark of stage N2. And similarly, occipital is giving you alpha wave, which is a hallmark of stage wave. So all 3 are important. Frontal, central, and occipital, all 3 are important. Similarly, EOGs. Similarly, EOG. So we need to have both EOG E1 and E2. You can feel the outer canthus. So we need to put EOG E2, that is 1 centimeter right and 1 centimeter up. Similarly, for E1, we need to put 1 centimeter right, left, and 1 centimeter down to have the both.
Just a minute, Pankaj. Mr. Prakash, kindly mute your window, please.
Okay, so then we have to have chin EMG channels. Again, now ASM is recommended a backup. So there is 1 EMG reference, and there are two EMG plus and EMG minus. That is one on the right side and one on the left side. So again ASM is talking about backup. So 1 EMG comes out, then we have a backup. So that is why it is placed. And obviously third one is reference, which is above the mandible. So now, in a nutshell, we have to have a pulse oximeter to see at the oxygen, to look at the oxygen desaturations. We need to have a thermistor to look at the apneas. We need to have both inductive effort belts for central apneas. We need to have a pressure transducer for hypoapneas to pick up hypoapneas. We need to have a microphone for snoring, leg movements, PLM sensors for picking up the leg movements. We need to have a body position, because body position is very important, because we are looking at supine RAM, because at this position, at supine RAM, there is a lot of obstructive sleep apnea happens. So that is why body position is very important. Then we need to have, obviously, you need to have an EEG head box. As I explained you already, we have to have, instead of 3 EEG, we can have 6 EEGs, better 2 EOGs, 2 EMGs, reference and ground. We need to have an impedance check. We need to have a synchronized video. Obviously, level 1 should have a synchronized video to pick up the movements of the patient, because you will not only get obstructive sleep apnea patients, you will also get different patients. As I told you, you will get RMD patients, rhythmic movement disorders, you will get RBD patients, you will get parasomnia patients. So you need to have a synchronized video for that. So this is what ASM recommends at the end. You have to have EEG, you have to have EOGs, 2 EMGs, you have to have 1 ECG, SpO2, respiratory channels. Then you have to have rip efforts. As I explained, you have to have snoring sound, and that is what video. So this is what ASM recommends. This is technical specification. We can leave that. Sleep prep requirement is basically, you have to have a room of 140 square feet size. You have to have accredited sleep lab. Medical director has to be board certified. You have to have attached bathroom, and you have to have a noiseless room, which ASM recommends. And this is a kind of ideal sleep lab. Patient should feel like sleeping at home. And that is it. If you have any questions, we can discuss, though we are very less people actually, but it's okay. Thank you. This is my email ID.